Welcome everyone to the Society of Thoracic Surgeons Adult Cardiac Surgery Database User Group call. Today is Wednesday. Is today Wednesday? It's today Wednesday, April the 20th. So as you can tell, I am not Carol, so I apologize. I am subbing for Carol today. She is off the rest of this week, so Melinda and I are tackling today's adult cardiac surgery webinar. So please bear with us and we will do our best. So let's go ahead and get started. On the call with me today, let's see who I have from the STS side. We have myself, we have Emily Conrad, and then Melinda, our ACSD consultant is on. And then from our IQVIA side, we have Jean, Joe, and Steve. So a small group with us today. But like I said, we're gonna knock it out of the park. For our agenda, I have a few STS important dates that I'll go over. Then we'll cover some brief STS updates. Next, I will give a very brief IQVIA update, and then we'll turn things over to Melinda for some STS education today. And then, as always, we'll wrap things up with the Q&A. If you have any questions, please be sure to put those into the Q&A function. I can't monitor the chat. So if you can, again, just please be sure to put your questions into the Q&A. That'd be very helpful. Also, we have the raised hand function enabled. If you would like to raise your hand and speak or clarify your question, again, please be sure to use that raise hand function and unmute yourself you'll have to unmute yourself on your end once I unmute from this end. All right. First, let's go over the important dates for the adult cardiac database. As you're aware, today we have the user group call. Our next call is scheduled for May the 4th. We have our ACSD monthly webinar at 2 p.m. Central, followed by our next user group call scheduled for May the 18th. The next important date we have is for May the 27th. Harvest 2 closes again on May 27th, and that does include OR dates up through March 31st of 2022. And the opt-out date for H2 is June the 1st. So be sure to get those opt-outs into us by June the 1st. Again, just to review, here is a Harvest 22 harvest dates for ACSD. As right now, we are currently accepting data for H2 of 2022. And again, that does close May 27th. Opt out June 1st, includes procedures performed through March 31st. And we are expecting to have these H2 harvest reports available this summer. So again, please note that we are looking to have these reports posted for H2 by this summer. For STS updates, Harvest 4 OR dates through September 30th, 2021. The Harvest 4 data was posted March the 14th. Also, please note that the April training manual has been posted and is available for you all. Harvest 1 data, OR dates through December 31st, 2021, is expected to be released at the end of this month. Please note that STS will send an official communication to the ACSD community once these reports are posted and are available within the IQVIA platform. Also, a reminder, if you need to update your contact information or if you need to get access for anyone at your facility, if you need to get a new user access to the platform, or if you need to deactivate access for someone within the IQVIA platform, please reach out to us at stsdb@sts.org. Just a reminder, the first step to making this happen is to complete the STS participant contact form. So again, if you need to update your contacts, request access for a new user, or deactivate a user, please go out to the STS website and download the STS participant contact form, complete that, and submit that to stsdb@sts.org. If you have any questions about that, completing that form, again, contact STSDB for assistance, and they can help you with getting that form filled out properly. AQO abstraction submission is coming up very soon. So the 2022 AQO meeting as you're all aware, is scheduled for October the 24th through the 26th in Providence, Rhode Island. Abstract submission will open soon, and again, that is targeted for May. Data managers and our STS database participants are encouraged to begin thinking about what quality improvement projects or scientific abstracts to submit for poster presentation. STS will be contacting all data managers via email once our abstract submission opens. So just please stay tuned. We will provide a link to the abstract submission site on the STS AQO webpage. And again, more information will be coming regarding AQO registration very soon. So again, we'll be sharing more information about AQO in the upcoming webinar. So just stay tuned. For our audit 2022, I do have a brief update. So we do have an update to the audited cases. The audited cases will include CABG, our valve, AVR, MVR, and MVR repair cases, as well as valve plus CABG. And again, just a reminder, Carol did present this on the webinar our previous webinar, I think that was April the 6th. The data pull will occur the week of May 1st. So any data in the warehouse at the time of the data pulled is the data that will be used for the audit. And sites will be notified in early May, early June if they have been selected for audit. So that information will be coming to you if you were selected for audit. As I stated earlier, I have just a very brief IQVIA update. Just please note that any submitted tickets are currently under review, and the IQVIA support team will follow up with any resolution or target release confirmation. And also just a friendly reminder, when you log into the platform, just give a quick check to review the notifications as well as the known issues document that is found in the IQVIA library. So just a reminder to check those two places, the notifications tab and the known issues tab, whenever you log into the platform, just to get the most up-to-date information available to you. But that's all that I have. So I'm going to turn things over to Melinda for our STS education.
Hey, Leanne, I was thinking maybe we should answer some of these questions before we start this, because they're kind of not they're related to more of updates and things like that.
Perfect.
And then we can do education.
Okay. Is there a report to find the national average for patients who had a post-op AFib event, but no history of AFib pre-op?
Well, I'm going to maybe turn this over to Joe. I know that we've been talking about having it reported for recurrent versus new. Joe, do you have any updates on that?
I do not. I would need to check with Melanie and see if she has any information.
That's what I was thinking too. So I'm sorry, I don't really have an answer for that. I know that there has been communication about doing that.
If you want to just email Carol for an update, and that way she can follow up with you when she comes back next week, that would be great. But yeah, if you could just email Carol, and again, she can provide an update to you directly. From Stacy, just to confirm, there will not be a 2023 ACSD version update, correct? That is correct. Lumedics is not aware of this per our monthly webinar yesterday.
That is correct. We have no plans for an adult update in the near future.
Yeah, and Stacy, I'm not sure. I'll have to check with Derek to see if communication was sent to the vendors. I assume all the vendors had been notified, but again, I will follow up with Derek, our STS contracts manager, who sends communications to all the vendors. So I will follow up with that on this end to make sure that all of that information has been shared with the vendors. So I'm making a note. Emily, the monthly webinar slide deck wasn't posted. Well,
Emily, the slide deck is sort of in the webinar. You have to watch the webinar. The webinar's been posted and the slides are included in the webinar. So you'll see it there. I don't think there's going to be a separate posting.
Okay. How often is a facility audited?
take
Emily?
this one.
Yep, go ahead, Emily.
So we audit 10% of the participating sites. So, and then if you're audited, then you are taken out of the audit pool for 3 years. So it's randomly selected, 10% of all of the participating sites.
Thank you, Emily. Yes, Kelly, I just wanted to acknowledge what a great job Melinda does in responding to STS questions. Thank you. Yes, she is
Oh.
absolutely amazing.
Thanks, Kelly.
And Rita, how do I go about requesting access to IQVIA for our senior VP who is interested in looking at the longitudinal reports? And actually, Rita, I am in the process of responding to your email. I have it up on my other screen as we speak. But since we have some time, let me go ahead and show you exactly where you need to go. So from our STS National Database homepage, the first step would be to complete the, where is it? The STS participant contact form, not that one, sorry. To complete the STS participant contact form. So go to database forms and then click on this link for participant contact form. And then you would proceed through filling out this form with your senior VP's contact information and submitting that. And once this form is complete and submitted, then the STS database team will get that person added and get them access to the platform. And again, I'll follow up with an email as well with a link and everything. So Rita, I will respond to you directly as well. Is there a way to see our STS indicators in a trend?
I'm
Melinda,
assuming that
yeah.
I don't exactly understand what I think she's talking about the dashboard, maybe
Yeah.
on the IQVIA site. I mean, I'm sure I don't know, Joe, what do you think? I don't quite understand the question.
I'm not sure what a trend means myself. Just I'm not
Yeah.
in the biz, so I don't know that terminology.
Yeah, if you could email Carol directly, again, I mean, I hate to keep adding to her emails, but if you could email Carol directly, and she may be more familiar
I'm assuming it's on the dashboard somewhere.
Yeah.
You can email me in the FAQ mailbox if you have more information exactly what you're looking for, and I can help you find it.
Yeah. Emily, this one's for you. Will there be a virtual option for AQO?
We are planning for it at the moment. We will we're in the process of contracting for a virtual meeting platform, and we will be able to provide you with registration information for both an in-person and a virtual option in the summer.
Thank you. All right. Kelly, what dates of surgery are eligible for audit?
This year it will be from 1/1/2021 to 12/31/2021. And it will be version 4.20. And I can answer the next one as well. So yes, in the previous audit, Carol did say that the audit will cover cabbage, AVR. That she is making a correction to that statement in that one slide. So if you want to pull that up, Leanne, it'll be cabbage, valve cases, AVR, MVR, MV repair, and then valve plus cabbage cases.
Thank you, Emily.
I think we should go to education now. Looks like the rest of these are
more into the
clinical questions. So
yes, ma'am. All right. So let's go ahead and then we'll continue with these questions once Melinda's update is done.
Okay, so hey everybody. First of all, I just want to say that our next call for the education, Nancy Honeycutt's going to be doing an aortic presentation. So you might want to mark that on your calendar because I know that everybody loves to hear aortic presentations. And we'll get started with this one. This is sort of a continuation from last month's call. We talked about beta blockers and you guys wanted some more clarification. So I just thought we would kind of go over the updates for beta blockers and review some concepts for beta blockers. So this This pertains to all beta blocker questions in the database. So that's sequence 1030, 1035, and your discharge beta blocker. So for beta blockers, you are only capturing systemic delivery. Okay, so this does not include topical creams, nasal sprays, inhalers, eye or ear drops. And I clarified that in the training manual because people were asking me questions about that. And I thought, well, okay, so I need to make this clear, but we need systemic, taken by mouth or IV type beta blockers captured, not eye drops and things of that nature. Okay, next. So let's talk a little bit about, I got a question on this one. This is sequence 1030, and this is the beta blocker within 24 hours. So how do I code for beta blockers within 24 hours of surgery? I have an AVR and ascending aneurysm repair. He did not get the beta blocker within 24 hours. My answer is either no or contraindicated. Which one is it? I do not get penalized for no, right? Because it's not a cabbage. Or do I put contraindicated because it's not required? So we're going to break this down because this is actually a couple of questions. This is very common of many of the questions I get in the mailbox all the time. It's not just one question, it's like a multitude of questions. So let's break this down in the next slide a little bit. So the first question is, how do I code for beta blockers within 24 hours of surgery? Okay, so this is an AVR, an ascending aneurysm repair. He didn't get a beta blocker within 24 hours. So my answer is either no or contraindicated. So which one is it? Well, the answer is that it's no, unless you have a contraindication that's documented in the medical record for medical reasons, or if the patient has an allergy to all beta blockers. So you would answer no, you would not answer contraindicated. And I think the reason she wanted to know if the answer was contraindicated is because she knows in her mind that pre-op beta blockers within 24 hours, the metric is only for isolated cabbages. So it was a good question and a good clarification. So just answer no in cases like this. Next slide. So the second part of her question was, I do not get penalized for no, right? Because it's not a cabbage. And the answer to that is no, this is not a fallout because this is an AVR and ascending aneurysm repair. The 24-hour beta blocker metric, the pre-op beta blocker metric, is only for isolated CAB patients. Next. We'll kind of go over this metric. So again, it's the percentage of patients aged 18 and older undergoing isolated cabbages who receive beta blockers within 24 hours preceding surgery. Next, Leanne, I'm sorry, you have to push down. The numerator is the number of isolated cabbages in which pre-op beta blockers is marked yes. The denominator is all patients undergoing isolated cabbages according to the procedure identification algorithm. Cases are removed from the denominator if the beta blocker was contraindicated, and the exclusions to this measure, your beta blockers marked contraindicated, or the status of your surgery is emergent or salvage. So if you have an emergent or salvage case that does not get a beta blocker, just code no. Those cases will be excluded from the metric. Okay. Next slide. All right, one more question here, I think, on this section, then we're going to go to the other beta blockers. I have an elective patient who is not on beta blocker therapy at home. The surgeon dictated the patient receive beta blocker within 24 hours of surgery at the beginning of his operative report. However, there is no documentation in the MAR or from anesthesia that the beta blocker was given. Can a pre-op beta blocker be coded? Yes. So let's look at this, break this down. So he's not on a beta blocker at home. The surgeon says he got one within 24 hours. So in order to do that, he has to take it at the hospital because he didn't take it at home. But then when she looks at the MAR and the anesthesia record, there's no documentation that this patient received a beta blocker at the hospital. So what's the answer? How should we answer this question? So the answer here is, in this situation, you have a conflict because this patient's not on a home beta blocker. And there's no documentation that this beta blocker was given prior to incision. So you're going to have to clarify with your providers because the surgeon's saying the patient got it, but there's no evidence in your medical record that the patient got this and the patient wasn't on one at home. So that was a really good question. I wanted to bring that up. And I think that because in the next slide, you'll see that we have an FAQ in our November of 21 update that kind of addresses this. I have an elective patient who is on a beta blocker at home. There's no med reconciliation done in the morning of surgery. If the surgeon or the anesthesiologist document beta blocker taken within 24 hours of incision, can the beta blocker be coded? Yes. And the answer to that FAQ is, for an elective patient on a home beta blocker with no medication reconciliation done, who has a surgeon or anesthesia documentation that the beta blocker was taken within 24 hours, you can code yes, since you have no other documentation of a pre-op beta blocker and no conflicts. See, that's the key. No conflicts in the medical record that indicate this documentation is not true. So the question on the prior slide had a pretty big conflict in my mind that had to be clarified because the surgeon was saying one thing, but there was no evidence to support what he was saying since the patient wasn't on a home beta blocker. And if the patient really got a beta blocker prior to incision, he would have had to have received it at the hospital. So just wanted to point that out. I can't remember who sent that question in to me this week, but it's a pretty good question and a good catch on the data manager's part too. So now let's talk about, this was an update in April, and I presented this on the last call, and we had quite a few questions. So kind of want to just bring this up again. So for sequence 1035, 1040, 1045, and 1055. And what this is the within 2 week beta blocker, calcium channel blockers, the long-acting nitrates, and other anti-anginal medications. So in April, we have an update in the chart, in the training manual. Patients that are on beta blockers, calcium channel blockers, long-acting nitrates, and other anti-anginal medicines, such as Renexa, it's like the only one I know, are to be captured if the patient is on them at home prior to admission. The reason we did this is because I kept getting scores of questions about, I know my patient's on a calcium channel blocker at home, but I can't prove he's been on it for 2 weeks. I've got no other documentation. How do I answer this? And so after scores of those questions, I decided to ask the surgeons, because the NCDR, for those of you who abstract for them too, allows you to say yes if the patient's on these things at home to this pretty much same question in their cath PCI registry. So after discussing it with the surgeons were like, well, yeah, of course, if they're not on the medication at home, we want you to capture it in this sequence. So that's what caused the update. So now if you have patients on home beta blockers, calcium channel blockers, long-acting anti-anginals, and other anti-anginal medications, if they're on them at home, you can say yes to sequence 1035, 1040, 1045, 1055. The other thing that this does is it shows you that the physicians caring for these patients appropriately were trying to manage these patients' CAD by placing them on these types of medications prior to surgery. Okay, so we can go to the next slide. We're going to do some scenarios. So, is sequence 1035 part of the star rating? Because I get this question, and the answer is no. So, for sequence 1035, that's the beta blocker within 2 weeks, is not part of the composite quality rating. The only one that's part of it is the beta blocker within 24 hours. So you don't have to worry if your answer here is no. There's no fallout or anything like that. Okay, the next slide. If the only documentation we have is the patient's home medication list, can we assume the patient was on the medications for more than 2 weeks? And answer yes to those sequence numbers. 1035, 1040, 1045, 1055. And the answer is
Oh, sorry. I'm sitting here, my cursor was on the wrong page.
and the answer
I
is
was
yes,
scrolling.
you can. We've updated this. So as of April the 1st, you don't need to prove the patients were on these type of medications for 2 weeks. If they're on them at home, code yes to 1035, 1040, 1045, and 1055. And the next slide. Patient wasn't on any anti-anginal medications at home, but he was in the hospital for 28 days prior to his CABG and received a beta blocker for greater than 2 weeks after admission. Would the beta blocker be coded as yes or no for sequence 1035? And the answer is yes. This patient, who was not on a home beta blocker, got a beta blocker in the hospital 2 weeks prior to his surgery. So yes, we're still going to code that as yes because he did get the beta blocker for 2 weeks prior to surgery, and he wasn't on one at home. Next slide. Patient was on beta blockers for more than 2 weeks prior to admission. Doses held for 3 days prior to surgery due to a contraindication. Do I code yes or no for therapy greater than 2 weeks? And the answer is code yes. Again, this particular patient was on it at home. And even if we stop them prior to surgery, we still want you to capture that these patients were on these medications at home because that demonstrates that the physicians caring for these patients were appropriately managing their CAD. Next slide. If a provider prescribes the beta blocker 2 days prior to admission, we will now abstract 1035 as yes because the provider's intent was to provide the correct treatment prior to his CABG. And the answer is yes. Starting with April 1st, 2022, if the patient is on a home beta blocker, a home calcium channel blocker, a home long-acting nitrate such as Mdor, or Renexa, then yes, we would code this as yes to 1035. 1040, I can't remember all the sequence numbers now, but you guys know what I'm talking about. Those meds within 2 weeks. I think that might be the last one, but I'm not sure. Oh, one more.
Sorry.
Is this my last one? Probably.
Yes, ma'am.
Yeah, I thought so. I knew we were getting close. If a provider prescribes, I think didn't I just do that one? Did I do that 2 days? Oh,
No, it's just the training manual.
Training manual
Yep.
updates. I wanted to point that out. That's what it is. So, again, this update was put in the training manual April 1st. So this will start April 1st surgery dates. And just to remind you, training and manual updates happen every month. They usually get posted usually pretty close to somewhere between the 1st and the 4th of the month, every month, depending on what days fall on the weekend and things of that nature. When you're abstracting data, use the training manual updates at the time of the OR date. So for example, if your OR date is November the 15th, then you should be, if there's a new update in December, you shouldn't be using the December ones. If you're behind in abstracting, you should just be using the updates up until the November training updates, because that's how the auditor will audit your record. They'll be looking at information that was available for abstraction at the time of the surgery date. I think that's all I have. So
Yeah, thank you, Melinda. Let's see, we've got quite a few questions, so I'll run through these slides real quick. Again, this is just a list of resources available to you. Again, if you have any questions, please reach out regarding your uploader, data quality report, missing variable report, dashboard reports, harvest reports. Please reach out to ACSD tech support at IQVIA.com for assistance. Again, phone number, and again, a list of contacts that you all are very familiar with. Here is Carol's contact information. Again, Carol Crone, the Senior Clinical Manager for the STS National Databases. Carol's email is here. Her phone is here. Database operational questions. Again, if you need a list of the contacts for your site, please reach out to us at STSDB. If you have questions regarding your participation agreements, invoices, things like that, reach out to us at stsdb@sts.org. Next, we will finish up with the open discussion. As again, we have several questions. So Melinda, you ready to tackle these questions? All right, let's go. First one, in an aorta procedure, when reconstruction the sinuses, a felt neomedia technique is used, do we capture this? And I'm sorry if I butchered that.
Well, I'm assuming you're trying to capture that in aorta device inserted. That's the first assumption on my part. We don't generally capture felt as an aorta implant. So if that doesn't, if I'm not on track, Kimberly, send it into the mailbox. If I'm way off track on that.
All right. Our next question, when will the STS public reporting website be updated? In all honesty, I don't know for adult cardiac. If you have public reporting questions, if you could please email Sydney Clinton at sts.org. And Emily, would you be able to put Sydney's email into the chat box?
Sure.
Okay, yeah, so if you have any public reporting related questions, if you could just direct those directly to Sydney. And again, she handles all STS public reporting related initiatives, so she will be the best to answer that question for you. I'm sorry I can't answer that for you off the top of my head. Thank you, Emily. All right, for sternal wound infection within 90 days of procedure, if it hasn't been 90 days since surgery before data submission, should we code no or unknown?
Jane Ann, if you're one of the sites that tracks this, which it sounds like you do, me personally, just because I have trouble remembering which cases I need to go back and fix, I always just leave it missing. I just don't answer it until after the 90 days. And that way, when I run a report, I'll get a key that is missing, and I'll know I better go back and answer it. That's what I would do personally.
All right, our next question, a case question. Patient had history of previous cabbage with bypass to LAD. LAD had 70% that was attempted for PCI and failed. During cath, the left main was resected, resulting to need for emergent cabbage. Patient for another cardiac surgery now. No new cath was done. Will the history be considered a history of left main disease or just LAD?
Okay, let me see. So we had previous cabbage, LAD was 70%. So that's a disease vessel. During the cath, the left main was resected. Patient had another cardiac surgery, no new cath. Will the history be considered? I'm not sure a resection would really necessarily I mean, I know it's bad. It's seriously bad. But when we look at the definition for disease and stenosis, I'm not sure a resection falls into the category of stenosis. I mean, it could kind of go either way. That's one we'd have to talk about. I think send me that in the mailbox because I can run that by the surgeons and we can get an update in the training manual. I could see it going either way, honestly. I know that's not a good answer. I'm sorry.
That's Melinda. And she will take it back. Would it be possible to have the answers typed in this chat box? Hard to keep up and take notes for my team members. That would be that'd be a little challenging. I know we had talked about, somebody had asked that before, and I know we had talked about that. I can bring that back to Carol in the group and we can discuss that. We would just have to it would be a little challenging for us. Like today, it would be a little challenging, but we can definitely take that back and think about ways to see if we can make that happen. So I appreciate your feedback.
Well, and you can always listen to the webinar, Donna.
Right.
I mean, the answers will be there on the webinar because it's recorded.
Right. How do we request IQVIA training for new data managers? I don't know if Joe or anyone from the IQVIA team wanted to take this one. I know we have some resources available out on the STS website.
We do. We could show them. We could show the resources on the website. That's what I usually direct people to do, unless Joe has some other tricks of the trade that he can share with us.
I don't think we conduct any kind of formal training. So if you guys have resources, I think that's probably the best thing for them.
Correct. Right. And for the STS National Database homepage, if you scroll down under important resources, we have the IQVIA, there's a checklist, and there's also transition resources, uploader instructions, a dashboard overview, educational, how-to videos. So I would start with this resource. And if you still have questions, please reach out to us directly, and we could help answer some additional questions for you. If you're looking for certain things out there and you're not seeing them, please contact Carol or myself, and we could help you individually. And there's also new data manager webinars that Carol and Melinda have done, and but I think you may be looking more IQVIA website report.
Yeah, under the data manager education section on the website, there are some IQVIA how-to videos down below that are there too. They're nice videos.
Yep. But again, once you start with those and you still have additional questions, please reach out and we're happy to help in any way.
Yeah, Leanne and Melinda, it's Jean.
Hi, Jean.
Yeah, I just wanted to support that. That's usually where we will point people, is to the website for STS. But if there's something specific they have, they can always reach out to us. But yeah, that's what we do also.
Okay, perfect. Thanks, Jean. Okay. And this was a comment from Bonnie in regards to an earlier question asking about trends. You can see quarter-to-quarter trend for risk models and complications on the longitudinal dashboard. So thank you, Bonnie, for pointing that out. So if you're not familiar with where the longitudinal dashboard is, I just want to point this out. If you go to operational reports and the longitudinal outcomes dashboard, risk adjusted, this information is available out here to you. So I would start here looking for trends. And if you can't find what you need there, then of course, just please reach out to Carol for more information, and she'll be able to best assist with you. I'm a relative new data manager. Can you tell me how, if procedures in the other aortas, et cetera, category impact our overall numbers?
Well, they're not analyzed cases. So they're not going to affect your star rating or your metrics. You will get an overall number of how many cases was done, and types of cases broke down. But as far as star ratings or metrics, they're not going to affect that. Unless they're analyzed cases, and if they're other cases, they're not analyzed cases. And aortas right now are not analyzed, but I know that we are working on a proc ID for aorta cases. And so in the future, they will, some of the aorta cases will be analyzed. I'm just not, I don't know exactly what stage that Dr. Desai is in with that on the risk models, the models for them right now.
Thank you, Melinda. Let's see, if the STS database will not be revised in 2023, and yay for no revision, we agree, would it still be possible to update the valve lists?
I don't know. I'll have to ask Carol about that, if we can do that or not. Maybe I'll ask her.
Yeah, I'm not sure. And then I also wondered, all right, Kelly put a comment in the chat box that there was an excellent presentation a few months ago on the resources available in the library. And I'm trying to scroll through our webinars page, and we also the STS YouTube page, just to try and locate that webinar. I can't remember which one it was off the top of my head.
I can't either. It was like December or November or somewhere, either first of the year or right at the end of the year.
Yep. So I'm trying to look through that. So, but thank you, Kelly, for pointing that out. Is next month aortic valve or aorta?
Aorta.
All right. And Nancy's presentation, will that be on the 4th?
Yes.
Yes. Important dates. Well, I'm not going to go that way. Yes. So
The May
the
4th.
webinar. Yep. The May 4th monthly webinar. Okay. Our next question, statins that are a one-time only dose equal, no, correct.
Correct.
Yes. I noticed a change of some of the other pre-admission meds from home, but not this one.
Actually, statins that's always been, statins is within 24 hours. So you'll notice that each medication has a different, some of them have strict time frames and some of them don't have as strict of time frames. And kind of each one of them has their own little rules. So statin is one of the medications that is within a 24-hour period. And also we don't accept a one-time dose of a statin.
Antibiotics usage refers us to the antibiotic guidelines. When reading it, appears aorta cases are excluded. So for aorta cases, should this be exclusion for the antibiotic question?
I would answer the antibiotic questions, Kelly. I think maybe exactly what I'm wondering if, I think I would answer the questions to all the cases. I don't, and maybe you can send me exactly what you're referring to in the antibiotic guidelines, because those guidelines were written quite some time ago. So I'd like to see what you're referring to. Thank you.
From Susan, it looks like you had issues submitting an FAQ yesterday. So yeah, I talked to Addie, who could not help. Listen to Carol. Carol is out the rest of this week, so she is not checking voicemails. So, but what Susan, have you been getting?
The site is definitely not broken, Susan. I had 50 questions in there yesterday. I got about 50 today. So it's definitely not broken. Okay. So it may be that I've heard maybe Google Chrome works a little better. I've also heard if you try to enter any characters into the submission form that you have problems submitting if you enter special characters. So if you still can't get through, just email it to me at moffer@sts.org and I'll put it over into my mailbox.
All right.
But it is working.
Okay.
Trust me.
Yeah, I haven't gotten any other emails inquiring about that. So, okay. So if a patient is on a home beta blocker, you can code yes, even if it isn't documented. That was confusing. In other words, if they are on a home beta blocker, you assume they took it.
That is only for, no, that's not, okay, let's break it down.
Okay.
So for sequence 1030, beta blocker within 24 hours, we make no assumptions. Okay, it's got to be documented that it was within 24 hours. For sequence 1035, beta blocker within 2 weeks, if they are on it at home, then yes, you code yes for sequence 1035. So we got 2 beta blocker questions there. One's within 24 hours. That's the metric. We got to have some sort of proof that that was given within 24 hours. And then the second one is for the beta blocker therapy for greater or equal to 2 weeks. If the patient is on a home beta blocker, then you can answer sequence 1035 on therapy for greater than 2 weeks as yes.
Where can I find a list of the quality composite measures?
If you go on the site under our resources, the STS adult resources, Leanne.
Yes, ma'am. Homepage.
And then go under adult cardiac. Nope, right
Sorry.
under adult cardiac. There you go.
I don't visit the adult cardiac page.
I know you don't. And then go to access data collection resources. I know. Bless your heart. You're doing so good though.
I'm sorry.
And then go down further. And you guys are going to see right here. This is the NQF endorsed measures at the very bottom down there. And that's going to bring up a lot of your quality measures right there with numerators, denominators, descriptions, and exclusions.
Very nice. Perfect. All right. Let me get this over here. All right. Our next question. Our medication reconciliation process only includes still taking as prescribed and not the last time each med was taken. Can we use this along with the anesthesiologist documentation stating beta blocker was taken within 24 hours to code yes to beta blocker within 24 hours?
I would say yes. Okay, so you've got a nurse saying the beta blocker, he's still taking it as prescribed, it's on at home. And then you have the anesthesiologist who has interviewed the patient prior to providing anesthesia, who is verifying that yes, this beta blocker was taken within 24 hours. So in that particular scenario, I think we have proof that that patient had the beta blocker within 24 hours.
All right, I believe I heard you say discharge beta blockers are not part of the composite. Please confirm they are part of the NQF measures.
Well, no, we have a discharge. We have a discharge medication. Beta blockers is part of that discharge medication composite. I said that the beta blocker within 2 weeks is not part of any composite, but if we pull up that NQF measures again,
Coming. Yes.
This is a test, Leanne.
Test. That's okay. I got it. Cardiac. Got it. Sorry, I'd actually closed out the screen, so I apologize, but I know exactly where to go.
Oh, look at her. Yeah.
I know.
See, there she goes. If we go down and scroll down to our medication at discharge, let's see, keep going.
Beta blocker.
Beta blocker at discharge. So there's your description of it and your metric there with your enumerators, denominators, and exclusions.
Okie dokie. Is there a report to find the national average for patients who had a post-op AFib event but no history of AFib pre-op?
I think we're working on that report. Jean or Joe, I don't think I have an update on that. Right now, I don't think it's broken down, but I know we've had a meeting about that. I just don't know what stage we're in, breaking down the recurrent versus the brand new.
Yeah, the participant dashboard would tell you who has an event, but it wouldn't be able to incorporate the history aspect. So I don't think we currently have that, but if there is something in the works, then maybe you know better than I do.
Yeah, I think they're in the process. That's in the process.
Yeah, we're working on it. We just
Working
don't
on it.
have it yet.
Yep, this is Gina. I think I agree with you on that one. So I just don't remember what the particular JIRA ticket that's associated with that, but I believe that's being worked on.
It's a work in progress. Correct. All right. What is AQO and are we required to participate in it? Emily, did you want to take this one? This is your forte.
So AQO stands for Advances in Quality and Outcomes, a data managers meeting. It's an opportunity. We bring together data managers and surgeon leaders to present on all of our databases. So this year it'll be the last 2 years it was virtual due to the pandemic, but we're going to go back into person. We're going to be in Providence, Rhode Island, but it will be a hybrid meeting. So we're going to be in person, but also if you are not able to make it, or some hospitals maybe can only send one person and they want an option for on-site education as well, we'll have that option. Adult cardiac, their content will be on Thursday, October 25. So, and it's not required, but it's just a really great opportunity to, get education on all areas of the data collection form or quality improvement. We'll have posters, and then on site we'll also have exhibitors, so you can be able to talk with your vendors. And we'll also probably have like a networking event as well.
So if you, oh no, I was gonna
Amazing.
say, I have the, from the STS National Database webpage, if you want to learn more about, go to our AQO website. If you go down to important resources, there's a link for Advances in Quality and Outcomes for a data managers meeting. And this reflects the information from last year, but as Emily said, it'll be updated very soon.
Very soon, yep.
For 2022, but you can just take a look around and see, look at the agenda from last year just to get a general idea. And again, all of this will be updated for 2022. So you can just kind of peruse through there and get an idea of the types of topics and presentations we had last year. So definitely recommend, if you're a new data manager, definitely recommend that you attend AQO. It's phenomenal meeting. So highly recommend. And Hannah also highly recommends AQO. Thank you, Hannah. All right, Melinda, had an emergent dissecting aneurysm that was repaired post-op severe aortic and mitral dysfunction. Sequence 6765, I can capture TAVR. How do I capture mitral clip?
I think if you say yes, transcatheter, that's going to capture both of them because they're both transcatheter repairs. So if you, for 6765, just say yes, transcatheter, that should capture both of those transcatheter procedures.
Is that dissection instead of resection of LMCA?
I would assume. I need to work with the surgeons to see if we want to count that as a disease or not.
I think Melinda said aorta education will be presented soon. Yes.
May the 4th.
Yep,
May the 4th.
May
Next
4th.
call.
A next monthly webinar at 2 p.m. Central. And also just know if you cannot attend that session, it will be recorded and posted on our STS webinars page. So don't fear if you cannot attend, it will be recorded and available for you to go back and review.
I'm reading it. Could you go over cannulation sites for perfusion? It is only where the initial site was entered. That's correct. It's your initial entry. If they put in the charting, purse springs were placed and a guide wire was passed in the femoral vein until it was visualized in SBC. Well, this is femoral vein cannulation then. They went through the femoral vein up to the SVC. So your answer is femoral vein.
Just an idea on the question about typing in all the answers. Can STS turn on this transcription option when recording via Zoom? And then everyone could reference the transcript for answers. Bonnie, I'll have to check. I don't know. Our IT manages our Zoom account, so I don't know what types of features they'll allow us to use. So I will follow up with that, but that's a good idea. Thank you, Bonnie, for that. I will follow up and see what options we have available to us. For pre-op meds,
1040 ask about calcium channel blockers for 2 weeks prior to surgery. 1045 is long-acting nitrate. Includes calcium channel blockers in the manual. So are we to say yes? So we have a category for calcium channel and long-acting. So if they're on both of those at home, then answer yes. Unless there's a typo in the manual, which I'm going to look at right now. Let's see.
do you want me to pull it up?
I've got it pulled up on my other screen, but let's see. Oh, I see. You're probably talking about that statement where it's talking about anti-anginal medications, and we're talking about the whole group, the beta blocker, the calcium channel, all of these different types. I assume that's what you're talking about, that general statement that's under each one of them. But if the patient's on a calcium channel blocker at home, code yes for calcium channel. If he's on a long-acting nitrate, code yes for that too. Patient had a coronary angiogram done showing 3 vessel disease and is taken for a CABG ×3. He returns 11 weeks later for a type A dissection. Ooh, that's not good. The coronary angiogram is repeated.
Not repeated.
Not repeated.
Right.
Do I code yes to cath done and 3 vessel disease? You know, I don't think we should say, I mean, we know that this patient's had 3 vessel disease in the past. So I would say, but you also know he's had a CABG. So for number of diseased vessels, 1170, once disease, always disease. So that would be 3. I would not put the same percentages in prior to the CABG. That would not make sense. So I'd probably leave those blank. I guess that's the best way to handle that. That's an unfortunate situation, that poor patient. So
Training manual doesn't state that you do not accept a one-time dose of pre-op statin given within 24 hours.
it doesn't. Let me look. Should. If you look under sequence 1135 under the yes answer, it says do not include a one-time dose. So that's sequence 1135 under the yes answer, says do not include a one-time dose. And that's probably just easily missed because it's after the green. That's what I suspect. Beta blocker within 24 hours. Nurse documents taking as prescribed in med rec morning of surgery, but not a date or time. OR nurse documents yes to beta blocker. Oh, okay. So, that's a new one. OR nurses generally don't assess the patient, first of all, because I was an OR nurse for a long time, if they've had their medication within 24 hours. But I don't want to answer that one. I have to think about that one because I'm not sure that the surgeons would think that would be acceptable. Send that in to me, Pamela, so I can review that with them.
All right. I know we're 3 minutes after, Melinda. We've got about 10 questions left. Actually, yeah. Do you mind? Do you want to continue on for a couple minutes? Okay.
I can if you.
Okay. Yeah, I'm good.
Okay.
Okay.
So the next one is for beta blocker within 24 hours. What if the patient states they took it before they came in to the hospital? Okay, well, if the patient tells you they took it, then that's verification. That morning, that's verification that they took their beta blocker. So I would say that yes, definitely. If he says he took it the morning of surgery, you could code yes. Donna, I don't know. I need to see what, this is the antibiotic question again. I need to see what your, I can't remember who asked the question. But what I need to see that reference in the antibiotic guidelines just to see what it's talking about. I'm not aware of that. So if anybody can send that in to me, that would be helpful because, like I said, the antibiotic articles are older articles prior to even us doing aorta cases in the database. So I need to. That's why I need to look at that particular documentation that you're referring to.
Are there any plans to align our discharge disposition to match CMS?
I'm not aware of any plans to do that. But Hannah, if you have some suggestions of discharge dispositions that you might like added that would align better, please send them in via the mailbox and I can put them in my upgrade file folder.
Excellent. Clarify, if there's no supplementary anesthesia documentation, but only the nurse mentioned that patient is still taking beta blockers prescribed, do we count beta blocker within 24 hours?
No.
Yep.
No. So in the example before, the med reconciliation was done, it said taking as prescribed. Okay, if that's the only thing you have, then you don't know if that beta blocker was given within 24 hours. You can make an assumption that it was, but you don't know for sure. The example above had the nurse documenting that taken as prescribed, but it also had anesthesia coming in and verifying that that patient had taken the medication in 24 hours. So in that particular scenario, you have proof and documentation that it was taken within 24 hours. What is the preferred PFT source? Well, the PFT, that would be the pulmonary function test. I think you may have sent this in the mailbox, Julian. I think I scanned it. So I can't remember exactly what you were asking me, but I think you were asking me the difference between a formal PFT and a bedside spirometry. And maybe it was your question and maybe it wasn't, but I would take the PFT closest to surgery. And if perhaps the one closest to surgery does not have all the information and you have another PFT within the time frame, you could get the other piece of information off the other PFT that's not on the one closest to surgery. Okay.
Long acting says to include calcium channel blockers. I'm asking if we enter yes to both.
I think she's trying to point, I'm going to have to look at this in the training minute. I think they're talking about that statement that talks about, but it could be, I'll just have to look. You have to look for sure. We could put it in 10, it's the sequence number, 1040, I think.
That's calcium channel blocker.
Well, the other one's got to be right there beside it. 1040. I'm gonna find it.
There's 1040.
I think it's that statement that did. Okay, so can you make that a little bigger?
Sorry. Yep. Sorry about that.
It's okay. You see this statement, anti-anginal medications right there in the middle,
Yep.
right there. That statement is under each one of the sequence numbers. It's just a general statement. But if you look at the definition of the 1040, we're looking for calcium channel blockers. If you scroll down, we're looking for long-acting nitrates, but you still got that same general statement talking about the importance of collecting it and why we're collecting it. And maybe that's the confusion. All I can think of.
If a patient has commercial Medicare, should we answer no to Medicare Part B or leave as missing since Part B only refers to traditional Medicare?
Well, if they don't have Part B, just answer no. That's traditional Medicare. Just say no if they don't have traditional Medicare.
From if access site to be captured as first site, when will we use multiple sites? As I think the indicator says to capture all that apply.
I'm not sure what question this is asking.
Yeah, we could. Here,
Chris, maybe you could send that in. I'm not sure exactly what you're asking me and what this is referring to.
Okay. In reference to CHF, patient diagnosed with CHY. I'm sorry, I'm not up on my. I'll let you read this one, Melinda.
In admission,
Yeah.
in admission, echo EF was 45. So this is heart failure, reduced EF, systolic. But patient still in hospital and a repeat EF before surgery has an EF of 55, which would be heart failure preserved. Which do I code? Okay, well, there's several CHF questions, Julia, so I'm not sure if you're actually asking about the CHF questions or the EF questions, so I'll just kind of try to tackle it all. So the patient is in CHF. I would take the heart failure type closest to surgery. And I would take the EF closest to surgery. Hopefully that answers it. Donna says, OR nurses do answer the pre-op bed given yes or no on our anesthesia also. Okay, so I need to get this clarified that would include nurses, because generally speaking on our medication documentation, it involves providers, so licensed like physicians, PAs, nurse practitioners, pharmacists. We've not expanded it to nurses, except unless, of course, it's the nurse is following a hold order or something. So that's why I need to clarify that. So that's a thing I need to get clarified.
Yeah, and again, that goes along with the comment below. If a nurse documents last time and dose of medications, why can't that be used? So, all right.
Well, no, the last
that's-
time a
last time.
medication is different than documenting whether they had it. Like if a nurse says the patient took the medication at 6 a.m. this morning, that's different than verifying and that this
okay.
patient took it within 24 hours. So
Okay.
I need to just make sure. I think it's okay, but I need to make sure that it's okay that we expand that type of documentation to nurses.
Please review what you just mentioned. Once a vessel is diseased, it is always diseased. There was a change update in October 2020 to this when a patient had a cabbage in the past and grafts are open.
Well, I'm talking about sequence 1170, which is number of diseased vessels. So once diseased, always diseased is still in effect. The update has to do with the coronary stenosis grid below of the current stenosis in the patient's vessels. That's what that cabbage with the open grafts update had to deal with.
This right here?
Yeah.
Okay.
So, so hopefully that clarifies that.
All right. And then Bonnie stated that she thought Chris was referring to cannulation sites.
She may have been, now that I'm thinking about it, but I can't remember the question.
I know, I was trying to go back to the question.
I'm sorry, guys. This is hard.
Yeah, I was going back to this. If access site to be captured as first site, when will we use multiple sites? As I think the indicator says to capture all that apply.
Well, yeah, sometimes you have multiple cannulation sites, multiple initial injection insertion sites. Not often, It's not often, but sometimes you do. And that's what that statement's referring to. But when you cannulate, we're looking for the site you actually stuck it in at. Not where it's going to, but where you stuck it in at.
So Judy, there's an option to put both for HF, acute and or chronic, and systolic and or diastolic.
Like I said, when you guys ask me these questions and I don't have sequence numbers and I don't really know what you're asking me, it's hard to always answer the question without looking at a data collection form and just trying to do it off memory, right off my head here. So if I look at that now, we go to sequence 911.
911's heart failure.
Yeah. So it says heart failure, yes or no. So yes, the patient had heart failure. Timing, you can say acute, chronic, or both. You can say both. I didn't address timing. I don't believe I addressed timing. And systolic, you can say both. You can say both, but on that particular echo, I don't know. I mean, sometimes when I see both, it's addressed as both in the same echo. They're not two separate echoes that say one says it's diastolic and one says it's systolic. And clearly with that EF, the second one was definitely diastolic and the EF pre was definitely systolic. So again, I'm not sure that patient was in both types of heart failure, but that's just me. I'd have to look at all of it a little closer.
From the net, we must have physician documentation of heart failure for sequence 911 rather than just the EF measurements, correct?
Correct.
Okay. Is a discharge echo mandatory for audit? My team is not performing one prior to discharge, only have the TEE post-op in OR. Occasionally they order one before leaving the hospital. Echo is done outpatient at follow-up visit.
And discharge echo is not mandatory at all. Physicians can choose to do an echo post-op or not. It's not required.
Referring to response for that cannulation sites for bypass, I think you said use the first access, but database allows all that apply. When would we use all that apply? Example, go through IVC to cannulate right atrium. IVC is not a choice, so I use other. What should I do?
Well, Nancy Honeycutt's got a great answer here. Back to cannulation. An example of when you would code more than one cannulation site would be when the surgeon uses bicable. Okay, so that's where he enters the right atrium and the SVC. That's how we would code it. Because we don't have an IVC choice in our in the database at this point. So our workaround is if you got bicable, that's two sites. Code is right atrial and SVC. Thank you, Nancy. My brain is getting tired. Thank you for helping me out with that.
One more question, Melinda. On that beta blocker, nurses should be allowed to put a note as we are licensed too, right? I know you're coming back to that one. So noted.
I understand what you're saying, Grace. I want to get that verified though before I make that statement. I know that you're licensed. I'm licensed too. But we, in the training manual now, in order to document contraindications, you have to be like a medical license, nurse practitioner, physician, PharmD, things of that nature. So I want to make sure that if nurses are going to be verifying that the patient took the beta blocker within 24 hours, aside from doing the med reconciliation. See, that's really where the nurses should be doing this, is on the med reconciliation. They should be doing their medication reconciliation and saying, this is the last date time that that beta blocker was taken, and that's totally appropriate. Or if the patient says to the nurse, I took my beta blocker at 6 o'clock this morning before I came in today, well, that's totally appropriate. But when the point that we're talking about now is we have language in the training manual that talks about surgeons saying that it was given in his op note within 24 hours. So we have anesthesia saying it was given within 24 hours. And there's nothing on the nursing reconciliation, because in that situation, the nurses aren't doing the reconciliation. So I need to figure out with the surgeons and leadership if we can expand that to nurses and not just anesthesia and the surgeons. Nurses certainly can document medications, but they should be doing it in the appropriate spaces, like their med reconciliation, or in their notes, clearly saying the patient said he took his medicine this morning. So anyway, that's the real point of issue here. And I hope that explains that.
Yes, ma'am. And Darlene gave another example of a multiple cannulation site. So.
Oh, good.
And yeah, and I put that's in the Q&A. So
Thank you, darling. You guys, my brain's getting tired. It's an hour and a half of answering questions nonstop. It's getting tired.
Yep. So thank you. I think we've gone through all of our questions and we hit 76 today. Julia has one last question.
Where can we code delirium? Well, right, we don't code for delirium. We don't have a spot. We don't capture just delirium, Julia.
Okay. Thank you so much, Melinda. You are absolutely amazing. So just a friendly reminder, important date for our next monthly webinar, Nancy Honeycutt will be giving the aorta presentation. And that is scheduled for May the 4th at 2 p.m. Central. So please join us for our next monthly webinar. Also, that webinar will be recorded, as well as all of our other webinars are recorded and will be posted out on the STS website. I will be sending today's recording over to our marketing team here within the next few minutes. So it will take them at least 2 business days to get this recording cleaned up and edited and ready for posting. So again, this recording, as well as the slide deck, will be available to you all to download. So just give us a couple of days. So with that, thank you everyone for joining today. We greatly appreciate it. Melinda, you are amazing. Thank you so much.
Thank you. Thanks,
All right.
everybody. I'm sorry. I'm sorry my brain got tired, but
Oh my gosh, no, you did great. You did absolutely amazing. So I hope you guys have a great rest of the week, and we will see you all on the next webinar. Thanks, everyone.
thanks. Bye.
Thanks. Bye.